Bonjour.
Hello, everyone. So, rethink the system based on professions or from the point of view of the professions. So, thank you very much for having organized this roundtable by, having been thinking quickly about this topic. I will try to replace Marie, who wasn't able to come here, very quickly. I was, well, basically thinking about all of this. I was thinking about the Oedipus. And I was basically asking this question: how did you know the answer? Well, let's say for this, when we say the animal that walks on four legs, then 2 legs, then 3 legs. Well, actually, I knew this the answer to this question very, very quickly, and I decided, so why wouldn't we start from the professions so that to really rethink the healthcare system? So Xavier Bertrand normally should be with us here today. Thank you, Mr. Minister. And I would like to offer you 3 pillars to discuss. The first one will be the state of things. The second one, to work on either opportunities or constraints and how you see them. And the third, in third place, I think that it's important for us to talk about the method, because that's what I love as well, because my grandma was always telling me that this is very, very important. I wasn't understanding it back then, but right now I think that this is more and more important. So the very first question, and I would like to probably give the floor to the elected representative, Stéphanie, RIST. You have a very important parliamentary experience. You have been working a lot in this profession. So what can you see right now as far as the state of things goes? We see that the technical progress is making the professions and the jobs evolve. So what is the state of things that you see? I believe that it is part of the context, and the context, as we have been saying for 2 days right now, is a transition, a demographical transition, the major one that is coming very quickly, because you all know the aging of the population, the increase of the chronic diseases, but also the insufficient quantity of doctors with respect to the population. And even if we are increasing the quantity of doctors, we will still need several years with respect to the very quickly changing situation for these doctors to really become operational. And we also have this relationship of each of these professionals who are entering in this transition, demographical transition, their relationship to their jobs. So everyone knows it, and the other topic is, of course, the financement of the system. So once we know the state of things, what I can see as a parliamentary worker, the first thing is that each of actors is unhappy with our healthcare system, each of stakeholders. So I have had complaints from the professionals, but also from the patients. And then I also think that we are covering our eyes and ears, and we are collectively irresponsible here. We have some skills, some professionals that are not used today, despite the fact that it could have improved the situation, probably the access to the healthcare or the quality. I believe that the expectations are not really adapted to the stakes of tomorrow, or even to the changes that are coming very quickly, like the artificial intelligence or technologies. And I think that, yes, we are innovating, but we are not moving fast enough on the innovations. So I think that this is the collective irresponsibility. That's what I would like to point out. Jean-Louis TOURAINE, I have known you as a specialist of surgeries in Lyon. So I have known you for years. So what is your idea about the state of things today? What is the key word for you? Well, I think that we have to rethink everything from the point of view of the professions, but even more from the point of view of the patients, because we cannot confound the means and the end result, because the end result for us is the well-being of the patients. So we are all here as means serving the patient, and I believe that everyone knows this sentence by Sir Auxerre, who was saying that the right doctor is the one who treats the disease, but the great doctor is the one who treats the patient who has the disease. And I believe that this is something that must really, really inspire us. And we have to think about it from the point of view of the patient. And the patient today is not at all the same as he or she was in 19th century. The values were remarkable, and we have to keep these values. But the system itself that has its values is obsolete right now. So the patient today is coming with information informations that are more or less good. Sometimes these informations are all bad, but they have information and they're asking questions. And we have to really make this patient participate in all these decisions. And this participation is even more important because even one patient that has participated in the creation of their scheme of therapy will have a very good observance of this scheme. That's what I would like to suggest. And finally, I think that this patient in the middle of the 20th century did not have the same pathologies that they have today, so the treatment was not the same. So typically, schematically, or from a caricatural point of view, the diseased with cancer, either they would no longer be ill or they will just die. Well, whereas today, this is completely different because there will be a huge, long phase of chronic disease. So this will be years and years of surgeries, chemotherapies, radiotherapy, immunotherapy, and so on and so forth. So it will be 5 years and so on, and 5 years or 7 years later, 60% will be healed, whereas the rest will be dead. But this is not reflected in the financement system or in the system. So the system is pretty much obsolete. And yes, of course, this is absolutely logical because in the middle of the 20th century, people are older and they have diseases that we didn't have before. So now, what you would like to say in the DGOS? So what is this balance with respect to the professional life that intervenes in here, and how do you see the role of the DGOS in this particular rethinking? What is the state of things according to you? So what we see today is that the need is absolutely huge. So this is, I think, obvious for everyone. So the transformation of the professions is absolutely urgent today. We all agree on that. So what else we can see here from the positive point of view is that we have this very huge acceleration of the process, because if we look at what we had a couple of years ago, we understand that we're moving forward faster and faster thanks to or because of the societal evolutions, because we are just obliged. It's mandatory for us to transform our professions, and the COVID was another accelerator for us. The parliamentary willingness as well, because we have some laws, the deputies Stéphanie RIST and the Minister Valtour-Nasolola, who are also pushing us forward to move forward, to share the competencies and skills and to transform our professions. So we are moving much faster, and we see a lot of different things in the visual field, but also the advanced practices. So everything is accelerating and moving forward. So we are in this stage of the implementation today. So how exactly can we make sure that people will move forward, move beyond their limits, and even like start implementing all of these changes? Because this is not always obvious, and this is why from time to time we have this impression that it moves forward very slowly, that we have the regulations that are coming very slowly, and we need to bring everyone together in front of around one table. But we don't have to forget about the goal that we have here is to make sure that the patient will have a part to play there and will have their place in there. So what is completely clear is that the transformation has to have an impact on the everyday life of the patient. Let's say the vaccine, they receive this vaccine, and this is an immediate change that intervenes in their life for the treatment, for the results, for the delivery of the medicine, for the, for some sort of disease. So there are some things that are very clear. So today I'm challenging many people here to explain to the patient in terms of direct access, whether this will be a massage therapist or the orthophonist or whatever other, let's say, professional or even advanced training, advanced practice nurse. So it's not really clear today. So I think that the visibility and legibility that we are providing to the patient would be much, much clearer. And the points that we have at the DGOS, I understand that we think that it should be part of the journey, because otherwise the patient is lost in there. They cannot see themselves in this journey, so the journey must be organized more or less. And the second thing is that, and this is the goal of all of our reforms, that we must guarantee the access and the quality of the treatment and of the care that will be the same for everyone. For example, to go back to this direct access, so that it will not it will allow us to probably free some time on some patients, but without having a negative impact on others, because in some territories it can increase the waiting time. So we have to be very vigilant here, and we have to keep in mind the fact that this transformation of the professions should be operational and should be serving the patient. Thank you so much. We were able to see the thoughts by the state, but also people who are in the field. So Philippe, I would like to probably provoke you a little bit, because I was working in this field, and well, it's interesting for the public hospitals. If you had less hospitals, what would happen? So what I am concluding from all the debates and roundtables that we have had is that we are having new jobs that appear. The technologies are favoring all of this. The paramedical jobs are also an interesting opportunity that appears in all the Western countries, and it actually allows us to reduce the waiting time. But at the same time, we have the crisis, patient crisis, in terms of the identity fear for each of these jobs, and this is very striking. The most striking example is the example of the doctors that are saturated. They have too many patients, and well, how do we satisfy the needs? We don't have enough work for everyone, and on the other hand, we are pointing some tasks that would probably be we could probably delegate them to the paramedicals, but we don't do it. And I believe that this is an important debate, and one of the causes of this situation, of this paradox that is contradictory for all of us, is that for us it's very difficult to really have this shared vision for 5 years approximately of this system. It's very difficult for us, and this is something that is related to the jobs. So because we can improve things, and it also concerns all the French, how in 4 to 5 years we can improve the access to the care, the access to the treatments. And at the same time, I'm going back to the question related to the hospitals and health. I think that this agreement is absolutely possible, and I have two ideas here. The first one is that I think that we have to recenter all of the stakeholders of the care on their own job. And the hospital has, throughout the year, progressively had introduced this conception of the jobs that is too extensive, ways too extensive. When we say the academic hospital, we see that we will be trying to achieve the excellency in terms of research, and then we will also have this proximity, but the proximity sometimes will not be at the level of the hospital, because when we are talking about the emergencies, well, the emergencies when I started my career, it was not seniorized. So we had some reports that were coming, and it was successfully, and we had 24 million people addressing the emergencies. So I think that with this idea, we have to strengthen this very first line, and of course confront them to the aging of population and the pathologies, and to strengthen them so that they will be protecting the hospitals. And the second idea is that we're basically we should be using this straightforward approach with the convenable cost that will correspond to the generation of baby boomers that will be aging as well. And we will not be able to face all of this without strengthening the services at home, but also the follow-up at home. And right now, the economical model is very fragile. We don't have the new one, the needed one. It's very fragile, and it's difficult. And for the emergency services especially, this is very difficult. And the fact that the home services were very much fragilized after COVID as well. So the default of this vision actually had an impact on it. Isabelle? Well, probably it's very interesting to talk about this, especially for you. So now, Olivier Mariotte, who told me, well, just make sure that he understood the question, which is why I actually selected for you to go just before last. Well, when I'm coming here, I'm always very careful, because generally we are like 10 years of higher studies and things like that. So I actually spent 3 days to try and understand what I will be saying. So first of all, the patient is the one who accepts the torture. So this is not someone who will be waiting for 3 to 4 hours or things like that. The previous round table, the resistance to change, we can see that the ministers are basically changing. So this is not at all the resistance to change. It changes a lot. So for the emergencies, I'm always shocked, because this is 50,000 consultations per day. So it's 1 million for specialists and 50,000 here. So we cannot manage that many patients per day. Well, I think that we have a lot of job to do here. So what is the problem of the jobs? Well, I have three problems. I don't have the problem with people who are cleaning or people who are cooking or something like that, but I have a problem with the medical stuff. I'm not talking about paramedical because I believe that it's difficult and degrading to say a nurse or a paramedical and so on. For me, this is doctor. That's it. So, but the thing is that it has been re-evaluated. But how? I don't really know, because I don't understand. We say that there are no interns. So how the private sector is taking interns and how many? Because it represents 35% of activities and we have 1% of the interns. So probably the public hospitals should also manifest and say, we are here. We are here. We also want interns. Like, for you, everyone is coming and asking you, and then everyone is complaining and things like that, and the same thing for you, for Marie. But I'm a syndicalist, but I'm not complaining. I think that everything is all right. We cannot always be in the negative, but at the same time, it's 30 million per year to have the interns. Back then, I had 10 of them, but right now the tensions are here, and we understand that we have to reduce this sum. So we need to evaluate all of this. 85% of the doctors that are working in clinics are liberals. Right now, they want to have a mixed model. Well, for me, this is impossible. So I have to probably rethink all of this and look probably at the public functioning mode and look at the rates so that to be able to provide a needed response. Now, for the medical stuff, for the nurses, well, I am careful here. Nurses, and we would like to not separate feminine and masculine gender in French, so I'm being careful here. We would like to have the equality. And yesterday, I actually took the membership for ChatGPT 4, and this is $70 per year. This is not very expensive. And I actually went there to ask how comes that there are more female nurses than male nurses. And he talked about the stereotypes and the 20th centuries and things like that, everything that we already know. But right now, we want to have equality. And if we want to have more nurses males than nurses females, maybe guys think that this is not the job that is for me. So 80% are females here. So here you will also say, yeah, in terms of money, we have a 15% of difference of salary between the private and the public sector. Is it normal? The Ministry of Work has asked us to look at the collective conventions so that to see what happens here and how we can change it. But the healthcare sector did not follow it. Hopefully it will follow at a certain point, because I have this problem with the doctors, with the nurses, but also with all the help and stuff. I think it's important for us for the caregivers as well, and we have to take into account all of them. Well, all right, I would like to stop you all here, and I would like to give this question very simple to Xavier Bertrand. As the next Minister of Health, but also as the President of the Regional Council, what do you think about all of this? Well, first of all, you gave me the floor last, and this is not very easy, because we can try to do like a synthesis, but this will not move the debate forward. But I was actually asking myself what I can tell about this topic, and if I am concluding, I think that it's not because I will just summarize everything that has been already said, but I have participated also in I have listened to the debates yesterday, but I believe that what corresponds to the healthcare system and what will be useful for us to really design it, but probably not for the upcoming 6 months, but for the 10 years to come. Well, I am used to say that in the healthcare system, the equipment, the buildings are crucial. So, okay, new treatments are crucial as well, but for the French healthcare system, these are men and women, and to rethink starting from the jobs, from the professions, I believe that this is really relevant. Now, for Jean-Louis Touraine, I think that it's not really starting from the professions, but we will be changing it, but from the patient, because I agree with Jean-Louis Touraine. I think that men and women are clearly making this difference, so we have to do it from the jobs and from the patients. So this is mandatory for us, because we see that everything is evolving very quickly, and you have been mentioning many times the artificial intelligence. So just a clarification, when we're talking about AI, well, this is with respect to what we have said, about the importance of men and women, because this will not be the jobs that will be replaced by AI, but the jobs that do not integrate AI will be replaced by other jobs. And the real topic here is how, in a certain way, we are really dominating and controlling AI, how we see it. And here I'm not just talking about the medical professions, but about all the professions that exist, because I see the caregivers and the AI, it has to be rethought and it has to be foreseen starting from now. Now, rethinking from the point of view of jobs or just the jobs. Well, this is the best way to really break down this silo policy of our country. And you have mentioned it a couple of minutes ago. This is clearly this notion of the mixed exercise that will allow us to, first of all, rethink the jobs. But rethinking the jobs will allow us to really move forward in this direction. But rethinking the jobs is also revaluing the jobs, and we have already said it, and revalue it not just from the point of wages, but also from the point of view of the new importance that they will have within the healthcare system, which is why I think with this question, well, we first of all have the question of the training, because we understand that the training is the question that can no longer be ignored. The initial training, of course, and Jean-Paul, I see, well, I received this question that you are addressing me by, completely, and I think that this role of the trainings has an important social interest, and I am ready to participate there 100% if the door is a little bit open, and if the door is completely open, like we can go fully into this new definition of the professions of the jobs to be able to move forward with this evolution. Well, I actually keep this question of the methods to the very last, because that's a really important topic. But coming back to the round table, is it a real opportunity, or do you see a constraint that does not allow us to accelerate, Philippe? Why does it not work? So what are the breaks or the hurdles here? Well, this couple of last years actually allowed me to really understand all these hurdles, or probably even to experience them violently. Right after COVID, I decided, well, we actually need two things. First of all, to give some more additional trust to the professionals. That's what we did, but also to tackle the attractivity of the jobs, especially from the point of view of their possibility of evolution. And I actually decided, well, I will talk about the intermediary medical profession, and then we will probably start discussing all of this. So it was quite important, because we actually started doing this report so that to really take our time for this evolution and for the dissemination of this report. So I talked about this evolution, and then I had many different consultations that I carried out with a lot of people, and I actually tried to understand all this violent reactions. Well, this is not very bad, because this is the parliamentary that makes choices and offers something, but these are also the violences among the professionals themselves, amongst, let's say, the doctors and the nurses, the violence that is on social media, which is very important. And what is also very important to understand, in my opinion, is that between nurses and probably caregivers, and we would like for them to evolve as well, and they are using exactly the same sentences. So what the doctor is using for the nurse will use the same exact sentences to criticize the caregivers, but badly criticize. So what are these hurdles, professional hurdles? For many reasons, probably the cultural reason as well, because when we're talking about doctors, we are afraid of the return of Monsieur Bovary. We also have this very strong lack of knowledge for the other jobs, and this is also an important hurdle. And there is also this fact, and we have mentioned it during the previous roundtable, the fair wages, the fair payment. If someone is consulting, and this consultation is easier and it takes me less time, so I'm not paid enough for some of the jobs. So all of these are the hurdles. And also we say that we have some over hurdles, which are also here impeding for the jobs in the healthcare sector. We also have this goodwill when we are creating a law or a decree or something, and Marie has already said we have to reconsult it. So we have some people who do not really agree on it, but we are trying to diminish the impact of the law that has been voted unanimously in the Assembly. And then you will have the over hurdles that will be here. And I'm here talking about this high authority of health that will be also uniting many people who probably do not agree among them. So you're adding all of this additional hurdles, and you are diminishing the efficiency of what was in this initial idea of the change of paradigm that was at the origin of this projects of law, saying that the person with a disease will come to our healthcare system, and because we trust our professionals, the professionals will take care of this patient just because only because they're in case if they're competent for that. Otherwise, they will reorient the patient. But we see that we have this hurdles over hurdles that are here and that do not allow us to advance. But we also have some opportunities here, right? Yes, indeed. And the very first opportunity that we have is that the actual state of things of our system is quite worrisome, so that we can compare it to what happened in 1945 and in 1958. So we are basically one day before the revolution, because we cannot keep the system that is obsolete, that is no longer valid. We can keep the values, of course, but the values are one thing, whereas the implementation of the system itself is another thing. And today we see that the system is no longer working. So the patients are no longer what they used to be, and the professionals either. So we have to adapt to the current period, current times. So this is an opportunity for us, because this is the right moment to recreate something with the architecture that will be totally different, with the mode of financement that will be totally different, with a new organization. So, long life crisis. Yes, indeed, because during the crisis in France, new children, I would say, are born. New systems, new things are born. It's not during the calm times that they're born. So this is French tradition, I would say. And in addition to that, I would like to say that probably each and every one of us has to learn this advantage of respecting all of these numerous jobs that exist today. Maybe they complexify things, but why do we do something simple if we have something complex? Well, we don't all understand all of this, but all of these jobs are here. And we very often say why the doctors do not call all the caregivers, all the nurses, all these new jobs, the engineers, artificial intelligence, and so on and so forth. So all of this is available to us. And through our fear, through our conservatism, through our fear of innovation, we continue to not delegate to those who are much more specialized in it than us. So we have to accept to delegate, to confer some power to these collaborators, to share this, so that they would be able to do something on their own way to for all of this caregivers, nurses, and all of this other people. So we do not have to decide instead of them. We have to give them the possibility to decide. That's what we have to understand. All right. So DGOS, well, we understand that we are talking about this balance and so on. So what are your powers and possible actions so that to help the system to be rethought? Well, the training is an excellent tool, an excellent opportunity, one of the best levers to transform our jobs. So the training has two aspects. The first one is to train a certain number of professionals, a big number of professionals, and today we have this problem, despite the fact, well, we actually have had many people talking about this. We have students in medicine, and we have the increase of 13–14% approximately of students in medicine. But this is not enough, of course, but this is the fact. We still see this growth, this increase that is here, and we have to make it constant. We have to continue it to make sure that this trend continues. So we have to improve the visibility, the projections, pluriannual projections of our needs in healthcare. This is for the professionals who are medical and not medical. This is really, really important for us, because if we have 13–14% in addition for doctors, we also have increased the number of available places in additional institutes for nurses, caregivers, and so on. So for the upcoming years, it's important for us to have additional visibility, more important visibility around our needs, and increase the number of the professionals that correspond to all of these needs. Now, about the equality of the trainings, well, this is not something that I will be commenting, because I believe that I'm not really sure that jobs are more attractive or less attractive to males or females, but if we're striving to get this equality, we have to get this equality in many different areas and sectors in our society. So now, going back to the training, I also believe that this is an incredible tool for the adaptation in the content. So we have to adapt our content, our trainings, to the jobs that we would like to have and to the evolutions that the system is imposing on us, because we have talked about the digital things. Well, of course, we understand that today the trainings are not adapted to all the stakes that are imposed on us by the digital, so we have to progress here. But then we also have to look at the paradox, which is also our paradox, for all these trainings that are medical and paramedical, because we say that they're not supple enough, they're not flexible enough, not agile enough. It cannot adapt as quickly as needed to all the transformations that we have mentioned. But at the same time, we're saying that reforms are always here and everything changes all the time and there is not enough stability for our students. We have to understand all of this. So I think that we have to inform, and we have been informing for a couple of last years, a lot. So I think that we have to find a certain balance in here and probably to adopt. So for the trainings, we have to do it, and for our professionals as well. To say whether we have a concrete example for the doctors, well, this is something that we have launched a couple of months ago, and hopefully we will be able to consolidate it in the upcoming months. We have decided to completely change the references of the job and the content of the job for the nurses, with all the evolutions that had occurred to it, because it was not rethought starting from 2009. So once we have the targets, the content of the training, and the training evolves, we have to make sure that it evolves completely. All of this evolves. So now this is an incredible transition. So to have all those jobs that are evolving and adapting, there is another question that I would like to ask you, even though I haven't thought about it before. So for these new jobs, will they allow us to have this wars between public and private sector and so on? So this is a question to the two of you. So whoever will take the floor first. Philippe. All right, so I think that this is something that we have said at the very beginning of this round table. In the reality, we have this internal conflicts, and this is what we see within these jobs. Let's say doctor against nurses, nurses against caregivers, and so on, because we cannot really create a certain order in our constraints and priority, because we understand that we need both of these sectors. Everyone knows it. So we are fighting. We have the disagreements at the level of the rates because we don't have a common point of view and a clear vision that will be hierarchized about the evolution of the healthcare system. If we create this vision, we will definitely have some disagreements, of course, but we will still have a lot of different other possibilities and other stakes and other challenges with drugs, with industries, and so on and so on. So we have this crisis that is about this identity dimension, which is an old one, because we don't really have this big picture in an assumed way, in a conscious way, I would say. That's my opinion. Well, I think about this age of war that you have used this term. So I think that in the interest of PLFSS, this regulation that we have, Social Security Financing Bill, I think that right now we have 250 billions, and right now we have 60 additional billions. So in terms of expenditure, how did we do before? I don't know, but I'm not really bored. So I would like for a caregiver to be able to become a nurse very quickly, so that they will be going to the second year very quickly. But people say that this is not possible. I would like for the pharmacists, because I'm a pharmacist as well, in our internal pharmacies, they must have like 10 years of higher education, diploma of 10 years, but you don't need it. I mean, 6 years is enough. So I would like for this flexibility. For the emergency workers, emergency services workers, same thing. For the pharmacies, I mean, so that they would be able, I don't know, to give some medicine against the cystate for the females. I think they should be able to do it. So who haven't had this client who came to see them one day? Could you please prescribe it for me? Right now, I need it. So I think that the pharmacists should be able to do it. They should assume their role completely next to the doctors, because you were talking about this convergency. Yes, of course, the rates convergencies. This would be absolutely fantastic. Perfect. So this is it. Well, we will not be really talking about the economical model. No, we will not be talking about money, but I am a syndicalist as well. I'm a trade unionist. So, well, and how can we converge all these different jobs? Well, the equality of wages, of course, because you will say, yeah, the doctors will earn more money. Yeah, maybe they have more turnover, but then when we're looking at all the expenditures, look at the hourly rate, and then we will compare, like seriously compare. I'm ready to do this. We have too many laws, and hopefully the Parliament today will put a break on all of this. But we just need some decrees for that. So we were talking about the transparencies of the accounts. In the clinic, we were saying your accounts are not transparent. Well, my accounts are given to the clerks, and if there is a law that it requires for us to do something else, we will do something else. Okay, so this is not a problem. So this convergency, okay, and we have to move together so that's to go even faster, and we have to derogate as well, because the innovation is not obeying, is disobeying. So all this medical innovation and so on. So the first person who did some surgery, they were attacked by everyone because this was experimental. So we have to ignore some rules, to break some rules, to disobey, so that to have some innovation. Because, well, I'm not. It's like people are not saying that I'm depressed and tomorrow I will die and things like that when they want to sell me something. But this is what I believe. So now, with in terms of the breaks and hurdles, I think that of course there are some openings. But what I would like to say here is that we have these false great ideas that are part of this of these breaks. The most recent robot, we have known it before the COVID, and we already know what this robot produced, and it was the disagreement in the offer of the care that is being given. And the hospitals are convalescent here, but we aren't yet at the end of this road, and we actually have to have the system moving forward correctly. And we also have the gaps that are important in our healthcare system that are still present. Let's say we still cannot talk about the jobs in the clinical and the technical clinical jobs. So this is not really rational. Now, these are the hurdles. Now, in terms of opportunities, because they're still here, we still have some interest toward our jobs. And post-COVID, a lot of Western countries said, well, these are important constraining jobs. And a lot of young people want to do this, and we can see it. A lot of young people want to train for that. This is a good news. And another question, which is political, and I would like to put it aside, is to know if we will increase voluntarily the trainings, and this is something that we have to do, and also to shorten the length of the trainings, we will be able to elude for longer time the question of the installment on the territory. But I personally do not believe in it, because I believe that in terms of the resources per country, we will need to have some coherence here if we would like to do something very useful for the French. So the willingness, of course, and second, I think that in terms of the new jobs, paramedical jobs, here we have a huge gap, and we actually have to work on that. And also we understand that we have some other jobs where we have something very interesting as well to explore, and we also have this topic, the preparation of the aging and the care at home. So I think that this is not really the reform of the financement, because the hospital is not like the 42nd reform of the research of Martin Gall in terms of the hospital, but it's the question of having a real economic model. And I'm here thinking about this example of the telemedicine, because we did it as a topic of the congresses for 25 years, but we still needed COVID so that to find finally the economical model for the telemedicine. Right now, the technology allows us to follow on remotely most of the pathologies. So that's very important, and this is in the best interest of everyone. So Xavier Bertrand, sorry, do we need to have a new Champeter in terms of healthcare? Yes, indeed. I understand, because it has been already said that we don't have the time for that. And right now we have to have this vocation of the emergency worker, but also the vocation of an architect. Yeah, but we say for the architect we need the time to think. Yeah, but look at all the work that has been accomplished in up to 2024. We have this roadmap already, and we're doing it for years and years. So we shouldn't be gathering year after year with the great ideas that are not really taken and implemented. So we have to act really, really quickly. And for the jobs, we have to work really, really quickly. And there are also some things that are not part of the budget-related questions. And I think that the director of the University Hospital Center had said during the previous roundtable that we don't really need the additional means, financial means, in health. And I completely agree with that. New therapists, the aging of the population, the fact that we did not really focus enough on the prevention, and this is something that increases the cost of the treatment. This is the field where the savings are possible. The double acts, redundant acts, it is possible for us to do some savings and to spend less here, and globally you will still have to invest more here. But there are also some fields where we do not need to spend more money. And Lamine has said it. Lamine has said it just right now, and I actually believe that we have to advance really, really quickly here. If we look at the nurses, well, to strengthen the role of the nurses in the care by valuing the clinical experience, that will allow also to the advanced practice nurses to go even further than what they do today, with this new mention that is opening here, and with all these places, positions, job positions that will be strengthened today. And I think that this is an important topic. This is part of the conventional topic, but some things can be pretty much implemented very quickly. But I believe that it can also give a very important orientation and fast orientation for our health-related jobs. And for this question related to the jobs, I haven't said it before that, I think that it's also something that will allow us to go into this logic of the mission for all of these jobs. And we all know about this. The main question here is whether we understand that the healthcare system that remains one of the best healthcare systems still. We have questions here that are related to the access to the care, but we have to recognize that if we want for us to really have this optimistic approach from the professionals, but also the real commitment, clearly we no longer have the time to stay here and think about all of this. We have to act. So now, going back to the method, because Jean-Louis TOURAINE, you have already explained to me this proverb about these stones, saying that the hardest is to not to say but to do. So what is the method? How should we do it? Because I'm looking at this Jacobin model. All the other countries that did some reforms, they have changed the system. We are no longer in the Jacobin system. Girardin model, this is part of the French spirit. So if we are accepting this, we have to accept the inequality, because by definition there will be some approaches that will be based on inequality. Should we have the formula of Georges Pompidou that I like? Stop bothering French, stop bothering the stakeholders, I could say here, let them do. So what is the method? How can we achieve this result? And do we still have a certain chance to find the method that will be able to do what we are looking for? Stephanie, I think that we have 5 points here. To, first of all, get rid of the taboos in our healthcare system. We have to talk about it, we have to debate, and we have to really, really put it under the projectors. The second point is to give the favorite possibility to innovation, experiments on the territories, just as Xavier Bertrand has already suggested. We have to support this. The third point is to give a vision to the system with the values that will remain from the system of 1945 and then the new system. And the fourth point is to make a lot of choices, because we had a lot of experiments, we have done the assessments, but now we are at the point of making a decision. We have to say yes or no, otherwise this is very bad. And the fifth point is the courage. I think we have a lot of this courage around this table, where we have to follow up on this in actions with the implementation. Yes, I completely agree with Stephanie. I believe that we need all these 5 points, and they must be translated into reality by a real policy with a willingness, and the policy that is based on evolution. Because I believe that with a Girondin system, but going out of the Jacobin system, we can look at the situation that happens spontaneously after the COVID, meaning the trust to those who are in the field. Because when we are, let's say, in the places without something for some equipment or something like that for the diseased people, so all the caregivers and nurses were here. Were we calling the ministry or IRS? No. People were calling from one hospital to the other, from one clinic to the other, from private to public, and they were renting the equipment and lending the equipment because they had more interventions in one place than the other. They were pretty much managing on their own. They were lending staff as well as lending equipment. So we have to trust people who are in the field. We have to say it. We have to stop waiting for a decision coming from above. So the top-down has to be replaced by the bottom-up. And then what I think, another thing that we all need here, and we probably need to delete, to break down some of the silos that are still here, because I believe that we are the recordsmen in terms of specialists in medicine, at least in in Europe, if it's not in the world. We have specialists and hyper specialists. Is it really intelligent? Does it allow us the needed flexibility? Because when we have the hospital beds and the stuff that is evolving and it's actually is responding to the winter infections, does it make sense in a country where there are some 3 other seasons and we have to focus on other things as well? Let's say for the transplants of organ, we have people who are specialized in some countries just for some specific analysis, and they will be doing just a couple of them per week. And mostly they will not do anything else. So you will understand that for this reason, in our country, for the transplants, there will be a lot of problems and lack of evolution. So we will have to change this. So yes, indeed. And how can we be a facilitator to make emerge this reflection about the change in the jobs? Well, you are also the facilitator because you are not just doing all the legislative acts and decisions. Yes, indeed. I share everything. I agree with everything that has been said, because we need some willingness, we need the courage, and we need the implementation. And at the level of the territory, I believe that it is essential to say that structural and structuring reforms are not coming out of the spirit of the high official representatives somewhere on top of the state in abstracto, because most often we are getting the inspiration from the experiences that are working, and Stéphanie has already said it. We did a lot of experiments during this last couple of years. This is where we get the ideas from, and we also have the reforms that are ongoing right now that are coming from the field. Let's say in terms of the access to the care, everyone is basically congratulating themselves for the new programs that have been done here, and the observations in some places showed us that it was working very well when we put around one table the emergency specialists as well as the liberal doctors. So we are basically taking the inspiration from the field. And then what I would like to say is that we need some dialogue. And sorry for being a little bit pragmatic, even if we have an emergency and we understand this emergency, we still need to have a little bit of time to think about what we need, what we really need, then to gather everyone around one table and to understand what works and what doesn't. Thank you very much. Well, we just have very little time left, so just a couple of words. Yeah, I would like to go back to what Stéphanie has said, and Jean-Louis as well. I agree with them. I have lived for 5 years with your peer when he was a minister, and it was less 10% in 5 years. So right now it will be like 20 years for the accounts of the health insurance. There was not a balance in there, but I would like to tell you, be careful here. I agree with Xavier. We will still need more means. Philippe, so we have 2 topics. Yeah, well, how do we do this? We need this vision that will allow us to create an order in our priorities and our contradictions and everything. And I believe that we will have a certain moment when everyone will have to assume their own responsibility, and we will have to have this method that will be very much shared with the civil society. And this is also the National Council of Resistance. That's what they do. This is the upstream preparation of the social and political effort. So that's probably a little bit different. And in second place, I think that we need to experiment big on 20 or 30 different territories for health, on the points that will be judged as a priority. And we have to accept the risk, accept to take the risk, because this is the main hurdle to not take the risk, because we have the system that has to breathe and to have this capacity to say that, yeah, we are taking this territory, and for several years we will be pretty much experimenting here. So what I understand, Bertrand, is that you have opened the door for us, saying that your region is ready. And Stéphanie said we have to help him. Yes, indeed. Stéphanie and Jean-Louis are completely right here. And hopefully I will not be compromising myself by saying that. But there is one thing. I really believe in the virtues of the experimenting. But I think that, well, it's not like we're opening the door, because for some years we have been able to observe that in the French system we do not trust the territories. Well, in policy we are asking French to trust us, but we are not trusting French. So if you want something to work, like experiments to work or something, we do not need half a century to assess everything and to understand what we need or what we don't need. So if we do not want to have the healthcare professionals discouraged, we don't have any more time. We are in absolute emergency. We can't have this architectural vision, and I think it's Jean-Louis who was saying that we are right now rethinking, changing everything. But I would like to say that we can no longer wait. The French are in need of this very massive and quick response. And, well, sorry for having repeated this, but I think that this is an absolute need. Yeah, thank you very much, because you have said that we have the possibilities and the courage. So, as far as I understand, everyone here has faith, right? The faith in the healthcare system and everything. So I think that this is a great conclusion for this roundtable. Oh, you also wanted to say something. Yes, indeed. What I wanted to say is that we have this collective responsibility in CHAM with respect to our organizations. Is all these rumors that I hear about the deletion of AMO, and I think 8 ministers were part of this, and I think that we have to mention all of this. That's very, very important. Thank you very much.